Okay, brilliant. So let's see if we can find people making their way in. I think people who are regular viewers of the webinars will probably be sick of me saying take in your virtual seats. So I'll kind of say it, but not say it this time. Okay, brilliant. We can see people making their way in, which is great. So hello, everyone. Good morning, good afternoon, or maybe even good evening from wherever you're joining us today. Welcome to today's webinar focused on hypnosis and virtual reality in pain modulation. What works and when? So today we're going to explore the evidence for non-pharmacological interventions in acute pain settings. We're going to explore a little bit about the mechanisms of action, and of course, clinical potential and everything else that comes in that picture. As we usually do with these webinars, we're joined by some leading experts in the area, and I'll give them an opportunity to introduce themselves in just a minute. You might be able to see them on your screen now. Carsten, Florian, and Emily, welcome. Thank you so much. But first, let's begin. Obviously, our regular viewers of our webinars will know that we like to do a little bit of housekeeping before we get started. Of course, this is a live webinar where it's a great opportunity for us all to engage in fruitful conversation, of course. So I encourage everybody here today to get involved with the conversation. And you can do that in a couple of ways. So you can use the Q&A function at the bottom of your screen to ask questions. You can also do this anonymously if you like, which is something I tend to do on a lot of webinars. And we will get to, of course, as many as possible of the questions after the presentations, where we'll be diving into the ins and outs of today's topic. So, unfortunately, due to the numbers, we aren't able to have people ask questions or make comments over the microphone. So please make sure you write your questions and do that as soon as possible is always preferable. Towards the end, we tend to have a nice flurry of questions once the discussion starts to get going, and often we don't have a chance to address them all. So my advice personally is get them in nice and early, but we do try and answer as many as we can throughout the webinar. There's also a chat function where you can share general comments, and it's a nice way to I guess a nice way to test this out for today's session is to hear from you right now. So please let us know. Pop into the chat where you're joining us from, perhaps a little indication to your background. Maybe you're a medical professional, maybe you're a student, clinician, researcher, whatever it might be. Let us know just down in the chat and we can see you there. We also would love to hear about your experiences with VR in pain modulation so far. So please, could you vote on the poll to let us know how you've engaged with VR so far? And we'll come back to that sometime soon. So hopefully you'll be able to see the poll sometime soon, and we'll review that in a moment. That is probably all the speaking that I need to do, apart from a reminder that this is also a recorded webinar, so you can access these discussions at a later time if you wish to do so via the EFIC Academy website and YouTube channel. That is enough of me talking. Let's have some introductions from our panelists. Guys, thank you so much for joining us. I'd like to first hand it over to Carsten. Thank you so much for joining us and taking time today, obviously, to be with us. We would love to hear a little bit more about yourself. If you could give us a brief introduction, that would be great. Welcome.
Thank you very much for this opportunity to speak at this web seminar. I'm really glad to be here and trying to open up the mind of what else is out there and what is new in the development of taking care of the patients that we are achieving to do. So my background is I'm a PhD student at Lund University. I'm having patients at Region Sjælland in Denmark. So that's where I'm based in an anesthesiological department. And normally I'm sitting and sedating people doing surgery. And as you know, awake surgery is kind of the new upcoming. So people that are being awake in a surgical setting is causing a lot of discomfort. We have blocked the signals from the nociceptive, but being awake is a big stress for the patient, being aware of all these surgical things. So I'm looking for what else is out there to lower the amount of drugs we are using, because we know drugs is also having all these side effects, and we want to enhance all that. So I've been looking into virtual reality as a non-pharmacological intervention, and I think it's a clinical relevant tool that I'm interested in.
Fantastic. That's great stuff. Very, very interesting, of course, already. But thank you so much for joining us. We can now hand over to Florian and Emily. Thank you so much for joining us. I understand that it's super early morning extra coffee time, right? Maybe we can go straight to Florian. Welcome. Thank you so much for joining us. Really appreciate it.
Hi, thank you for the invitation. This is actually a real pleasure for me to talk about this subject because I studied in my PhD thesis about virtual reality for like 6 years. I'm a work psychologist and a researcher, so my purpose in the research is to evaluate, to create, and to implement non-pharmacological techniques, so complementary techniques to in the medical field. And virtual reality hypnosis was one of the most tool I could use with patients in my thesis, but a lot of others, also music, dance, and a lot of other possibility for them to use their own resources to manage pain. So I'm really happy to share the result of our work with Emily about this subject. Thank you.
Yes, thank you. Thank you again so much for the invitation. So my name is Emily. I'm a PhD student in clinical neuropsychology at Université de Montréal, and I'm working in Pierre Rainville's lab since 2020. And I had the pleasure to work with Florian and the research team on this experimental project with VRH. And for now, for my PhD, I'm actually working on the effect of certain emotions on acute pain. So that's it for me. Thank you so much.
Fantastic. Great stuff. And again, thank you for joining us on such an early morning, which is great. Really appreciate it. So we can see people in the chat. Shahid, welcome, of course. Leandros, welcome. Felipe, Bart, Jani, thank you so much for joining us, guys. Please let us know if you haven't already where you're watching from and a little bit about yourself in the chat. Okay, we also have some VR, the VR and pain webinar poll results. So the question was, have you used or studied any of the following in pain modulation so far? So we have 50% no direct experience. Interesting. That's exactly what these webinars are for. So hopefully there's going to be a lot of learning for those individuals. A good bunch have studied but not used them clinically. Kind of the same amount, maybe a bit less, has used hypnosis clinically, of course, but maybe not VR facilitated hypnosis. And a very small percentage have used VR clinically and both. So bit of a kind of an overview. It's a good kind of blank platform for around 50% of people, which is nice. So I think it's time that we get into the presentations. Again, thank you so much for joining us. A reminder to obviously add your questions into the Q&A and into the chat as well. Carsten, thank you so much. Do you want to go ahead and begin your presentation? Thank you.
Yes, thank you very much. I hope you all see it here.
So we just see a banner.
Oh, that's not supposed to happen.
That's fine. We'll give it another go.
We need to give it another go. That's right.
Absolutely. Yeah. And just while you do that, I'll answer Marta's question, which is, will the recording be shared? It will be accessible on the EFIC online education platform and YouTube channel. So if you can't make the whole of the presentation, you can access it at a different time, Marta. Brilliant stuff. We can see the presentation. Go ahead, Carsten. Thank you.
So everything is working fine now, right?
It is indeed.
Thanks. And again, thanks for this invitation to do this presentation. And today I will discuss virtual reality as a non-pharmacological adjunct to acute preoperative care. The focus of this talk is not technology itself, but rather a clinical question: how can we improve patient comfort in acute care without simply adding more pharmacology? I will present the evidence from our systematic review, discuss mechanism of action, and finally address what it means for real clinical implementation. My name is Carsten Lassen. I'm a nurse anesthetist. I'm a PhD student at Lund University. So my daily work is working with patients and giving them sedation. And surgery and anesthesia has come a long way, um, making it less stress for the patients. And to do that, I will bring in some of the knowledge from virtual reality. Here is just a short agenda. But as a anesthetist, we know that being awake for surgery, that is the new trend of taking care of the patients. We know that general anesthesia has a lot of side effects. It's prolonged the stay in hospital stay, and we want to make it better for patients. Also, the gap of there's a lot of need for surgery, and that is a rising demand for surgery. But we don't have the staff for that. We don't have the facilities for that. So how can we shift from having people staying long time in the hospital for shorter stays, fast surgery, and enhance the recovery? Well, we know that the surgery techniques have developed, so being less invasive for the anesthesia. We've been developing regional blocks, and then means also being awake for the surgery. But being awake for surgery is having also the stress on patients that normally we address with sedatives to being in that settings, being around all these settings of noises and talks of and can hearing what is going on, put a lot of stress on the patients, and then we normally add sedatives for this matter. And non-pharmacological interventions have also been looking and having great results, like music or mindfulness have been showing great results. But to push further on, there's new winds blowing, and that's why I want to talk a little bit of virtual reality, because we can see a total rise of testing virtual reality in a clinical setting and doing surgery. So we wanted to find out what is virtual reality, and is it something that we can use in a clinical settings? Taking it a context, being there and being in a virtual reality, maybe take the view of what is going on and put the patient in another virtual reality, and therefore we can lower the amount of pain and anxiety, and that's how important it is. Um, and I also want to just shortly address, why am I talking about anxiety and pain together? Well, from a clinical perspective, anxiety and pain is highly related. So when you're having a awake person, we know that anxiety also have impact on pain, on how they rate themselves as on the pain rating scale, and also the other way around. So finding something that is working in interoperative is a great thing to test if the efficacy is good for the virtual reality. So you will hear me talking about, and I'll show some results on the pain from the meta analysis and also from anxiety, and we think that's are related to each other. It's also important to talk about what is virtual reality. We define virtual reality as a proper head-mounted device that are specific developed for this purpose. And why is this important? And that is because over the few years we have seen a fast development of virtual reality, starting from a headset that was 8 kilograms heavy to sitting close to a screen or just sliding in a cell phone. We don't see that as a proper headset so far. So we have been only looking at headsets that are developed for that purpose, specific purpose, with its own glasses and screen inside. So that's, you have to have that in mind as what we define as virtual reality. So as an anesthetist, a nurse anesthetist, I'm sitting there and using these drugs to have a comfortable patient in mind, and I know that drugs is working. So introducing a technology or a fancy thing, I have to know if this is something that I can use. This is something that I can trust. And just to put virtual reality into a geological frame, what we think is at play when we talk about virtual reality and modulating pain and also anxiety and what is going on there. We're looking at these mechanism, attentional capture, and we believe if you have immersive sensory engagement, that means you have blocked out everything else you see. You only see what's inside this screen. It's a good quality. You have noise canceling headphones. You're making immersive sensory engagement. Then you will have these benefits of action. You will also have a modulation of the top-down mechanism. That's what we are looking into and assuming that is happening. We also have the affective and anatomic regulation, anxiety, and somatic arousal if you have a focus away of this. And then we will hopefully see the clinical effects of lowering pain and lowering anxiety. I have links. You can see some of the articles that are great exploring the mechanism behind virtual reality and what is going on in pain. It's not just, as I was saying, pain is not just input from the body, it's an output from the brain. It's kind of provoking in some way, but I think the modulation of pain is also something that is interesting to look at, especially when we're talking about virtual reality and the benefit of that. A great guy, Hunter Hoffman, have done some research on virtual reality, and he have proven this that you can see that the modulation of areas in the brain that are known to be activated during pain, and he compared virtual reality with morphine on healthy patients, and you could see the same areas lowering activity with reality and morphine. And so it's not just something, it's the only distraction tool. No, it's actually something that is working in our body. And I think that is important to remember when you're taking in new things in making a better workout or setting for the patients. So I want to draw out some of my the results that we've been collecting in the virtual reality. We did a systematic review with meta-analysis and with TSA analysis also. We wanted to gather all the evidence on the market so far on virtual reality. And we want to take all the evidences available. It's not just RCTs, but it's also cohort observation studies and collect all that. And we've been reported that in this article. And as I said, I will draw out some of my conclusions on that or the results. I know this is a really busy slide. I just want to point out that we limited the evidence from 2007 because of the development of technical development of virtual reality. We also only included virtual reality that was in our definition, and it has to be doing procedure outcomes that they have reported on. So it's not 6 hours later, it's not 20 hours later. It have to be doing or immediately after surgery procedure is done. We wanted to be specific on that. What is the benefits of anxiety and pain? And I'll report on that also. And here is my forest plot on pain for NRS 0 to 10 on a rating scale. And all these studies show there's a significant difference lowering pain in the VR group. And immediately you see here it's 0.87, and that doesn't fulfill the minimal clinical important difference, as we said also. So we said about this is a significant result showing that virtual reality has a beneficial on pain lowering, but the minimal clinical important difference, as we set it to 1.5, is not reached. I will come back to that. What is that meaning? Also, anxiety for NRS measured. Here it's 1.31, and also significant lower anxiety for the VR group compared to standard care. Also showing that NRS anxiety is lowered for the VR group. And here is state tray anxiety inventory, another scale used to measure patient-reported outcomes for anxiety. And here you have minus 6.87, and here you reach minimal clinical important difference. For some studies that is mentioned for is 6 or to 6. So here is a more robust signal that virtual reality has a beneficial for that also. Here on time in recovery room, we wanted to explore, can we take away the effective the time in recovery room? Is that also a matter for in-hospital stay? And we only had 2 studies reporting on this. This is definitely beneficial for lowering the time in recovery room, but I will call this exploratory outcome because of the lack of further studies. Another thing when you take things in to a surgical or clinical setting is, does it do any harm? And we will also investigate the harm side. So we have been taking out results that for these studies reporting on serious adverse events or adverse events. And we found that adverse events are rare and mild. They're more normally commonly reported as dizziness or cyber sickness. Cyber sickness is nausea basically, and there's no signal of serious events to virtual reality. Of course, there's limitation in the literature. There was a significant heterogeneity across studies designed in VR virtual reality, but that is also you will see of the variation of content. So there's a lot of variation in the content. That was also showed a lot of risk of bias in the reported studies, and the evidence was moderate to low. And the variation in also virtual reality headsets and the content was not fully addressed. As you saw in the pain forest plot, there was a lot of variation in outcomes. Some studies showed beneficial, some couldn't find that in favor for virtual reality or even favor for the standard care. And that's also because we took in every medical or surgical procedure, not just linked to one surgical. And it's also shown that its content or situation limitations. Another thing is why these studies the differ across these studies. The baseline anxiety and pain levels was vary. Some of the groups was in the standard care used sedatives in control groups, and they didn't find a difference. So some studies saying that the virtual reality it was not significantly better than drugs. And the procedure type and duration was also a difference. Some, I think there was down to 6 minutes and more than 1.5 hours, where you had to have virtual reality or standard care. And also, again, virtual reality and content vary widely, and that's also a limitation. But still, our conclusion from the systematic review is virtual reality is an effective and safe supplement for reduction anxiety and pain in adults undergoing surgery. As I showed you in the recovery room, evidence suggests shorter recovery period, but further validation is needed. And we need to have further research to conduct larger standardized trials alongside long-term outcomes also. We need to have multi-center trials to establish the knowledge about virtual reality and actually to finally integrate virtual reality into a multimodal strategy for pain relief and also for guidelines for clinical use. So talking about where can we use it in the clinical information, I definitely see virtual reality where there's a high anticipatory of anxiety. Situation where sedation is undesirable or limited. For example, rural areas where the lack of staff for anesthesia for potential dangerous drugs. Maybe you can do a procedure with virtual reality and have a better comfort with the patient instead of just stick to Biden, as I say. Also, I can see virtual reality as a young to standard anesthesia. Also shorter procedures. And also awake minimal sedation patient procedures as a regional anesthesia. I could definitely see virtual reality comprehend the comfort for the patient. But what is not useful for virtual reality, as it is right now, there is definitely development in virtual reality, and we see that really fast when we're collecting data from the first time in the systematic review, and then we did 1 year after. There was a huge amount of studies between these two periods. We also see that effective is not effective for all patients. So it's not a plug-and-play solution for without a clinical framing, I would say. You have to put into what is beneficial for that specific clinical setting. And I think that's really important to address that also. One fit doesn't fit all. And so we've seen a lot of evidence out there, and so why is it not used more in adults? We have seen it used in kids. We use it more and more for distraction. The kids doing medical procedure or venous puncture and stuff like that. But why are we not using it on adults when we can see that definitely a benefit for some patients? Well, there's a time pressure in acute care, and also I would say there's a culture. As an anesthetist, a nurse anesthetist, I'm used to use drugs. I know drugs are something that I will get the patient to be comfortable in, but I also know it's a side effects. So we need to have the culture change also to bring in new technology, and also address the hardware comfort. Having a VR headset on, maybe you have glasses. We have to have headsets that comprehend glasses on there, or laying down, sitting up, how heavy they are. Maybe you're laying on your stomach. You can still see something there, but that's also a limitation. And also, we have to investigate what content is working at specific time or clinical setting. And there's definitely a lack of standardized protocols. A lot of people is taking content that they believe this is something that is really good, but testing what has been shown to the patients is also something I think that is we need to do more of. So to wrap it up, all as I say, as a periodic care shift toward awake ambulatory surgery, patient comfort must increasingly be achieved with less pharmacology. Virtual reality is a clinical relevant, a low risk adjunct, reduce anxiety and nociceptive silence. So if you have one take-home message, I would say yes, you can use virtual reality. We need to develop more. We have to investigate it more. But there's definitely growing evidence behind all this. So thankful to supervisors at Lund University, Talet, and Region Sjælland for this PhD project. If you want to link up with me, you can take your phone and there's a QR code there. But I'm happy to take questions after this. Thank you very much.
Thank you, Carsten. I think that image at the end kind of, the mother, she's always saying, don't sit too close to the television, and then you go and do some work in VR where you really take it to the next level. Carsten, thank you so much. There's lots of questions in my mind, and I'm sure we'll see some questions coming through from the audience as well. Thank you so much for the presentation. We're going to obviously take some questions towards the end. So first, we're going to have a presentation from Florian and Emily. Welcome. Thank you so much for joining us. We're going to move straight into that one to make sure that we have some time at the end to answer the questions. So I hand the floor to you guys. Thank you so much for joining us. I hope the coffee started to kick in just a little bit.
Emilia, I think this is, yeah, perfect. Okay. Hello, everyone. I'm Florian. And I will present you a study that we created with Emily about virtual reality in the management of pain. So thank you, Carsten, because you really introduced the subject for us, because I really want to go straight into the subject now. So we know that virtual reality is a real effective tool to reduce pain and anxiety in some cases, not for everyone, but in some cases, via immersive multisensory distraction. And in Belgium and in a lot of hospitals in other countries, we use also hypnosis to modulate pain perception. And we use suggestion to help patients to regulate emotions. So both approaches show clinical and experimental analgesic effects. And there is expectation in the medical field that maybe if we combine hypnosis and virtual reality, we will increase the analgesic effects. And maybe this tool can be used with a lot of patients instead of maybe hypnosis being more difficult to have the imagination for the suggestion. So the virtual reality helps to have that image and that immersion, which is really direct. When I began my thesis in 2018, there was not a lot of studies in VR age, even in VR. And this one, we created this study with researchers, psychologists, anesthesiologists, and medical team, because there was a question about maybe we can use virtual reality hypnosis in a very complex medical environment. And here was in the intensive care units. So we can see on the photo that patients in intensive care units, they are in a particular environment, and they also already have physical trauma, emotional trauma, difficulties to sleep, and they have to recover from very severe injuries. Here, the patient had open heart surgery. It was the day 2 or day 3 after the surgery. And so we wanted to know if hypnosis alone with just audio, or VR alone with just the image, or the VR age, image and suggestion will help people to manage pain and maybe anxiety. And the purpose was to give them a place to rest in the, like we can see a lake with a little cabin, and a place to rest and to be dissociated from the hospital for a few minutes. So we compare control, hypnosis, VR, and VRH in 100 patients in intensive care units. And the results showed that we had a decrease in anxiety in all the groups, including baseline, an increase in relaxation in all the groups, and no significant effect on pain, fatigue, or the use of opioids. So these results were very surprising for us at this time because we really believed that the VRH would be more efficient than the other groups. So we don't really know which technique will be the more efficient for these patients. And that is why we asked the help of Pierre Rainville and Emily because we wanted to know, okay, maybe this is because we are in the clinical medical setting and the the the, the environment is already really complex to find significant results. So we wanted to know if we can ask the same question, but in a laboratory with healthy participants. So does virtual reality hypnosis provide greater analgesic effects than hypnosis alone or virtual reality alone on subjective pain perception and physiological nociceptive responses?
Yes, so to answer those questions, we recruited a sample of 24 healthy adults in Montreal, and people should have no chronic pain or diabetes or certain conditions and medication, as well as no phobia concerning deep water, since the virtual environment we used was underwater. So it was something to keep in mind. I did not write it here, but for this study, we recruited 13 women and 11 men, and the mean age was about 30 years old. So participants came in the lab for 2 sessions. I will talk about it a bit more later, but we use electrical stimulation to produce acute pain. And so during the first session, we assessed the individual pain threshold, and participants were also invited to test the VR material. So just to ensure that they did not experience any nausea or dizziness before the second session, which was the intervention session. So we administered the baseline firstly, and followed by the 3 experimental conditions following a within subject design. So there was the VRH, obviously the VR, and the hypnosis alone. So the 3 conditions were presented in a counterbalance order to avoid any potential order effect. And for each conditions, participants received 10 electrical stimulation they had to rate. So they had to rate the pain they felt. So here is the definition or the description of the different conditions. So obviously baseline is with no intervention and people were asked to keep their eyes closed. The recorded hypnosis is just the hypnosis alone. So it was the hypnotic induction with a guided relaxation and some comfort suggestions. So there were no suggestions related to pain directly. So it was just like a relaxation, and people had the headphones on and they had to keep their eyes closed also. For the VR, as I said, it was a like underwater environment. So you can see here what people saw. So they just viewing the relaxing environment without any audio. And for the VRH, well, it was the 2 combined together. So they had to the cask and the headphones to listen to the recorded hypnosis while being in this the same environment. So now I'm going to talk a bit more about the acute pain protocol we used. We used painful electrical stimulation in order to produce and quantify the nociceptive flexion reflex, which is the NFR. This corresponds to the spinal nociceptive activity and is independent from supraspinal input. So people had the electrodes at the ankle, and we administered the stimulation here, and it was producing a reflex. We first, as I said, determined the individual threshold using the staircase method, and then electrical stimulation were administered at an adjusted intensity to ensure a reflex. So it was adjusted to everyone. And the reflex response was measured using the EMG, so the muscle activity following each of the stimulus. So this was our main physiological measure. And we also add self-reported measures, so which were pain intensity and pain unpleasantness. So people had to rate them from 0 to 100, 0 meaning obviously no pain at all, and 100 being like the most intense on unpleasant pain you can imagine. So intensity refers to kind of the volume of the pain. And the unpleasantness refers to how it bothers you. So it's two different components of pain that we measure. So they can vary together or differently depending on the context or other factors. So regarding the data analysis, I'm not the expert here, so I'm going to try the best that I could. But rather than relying on p-values, we decided to use a Bayesian framework with paired sample t-test. And the key advantage here was to let's quantify the evidence for both for and against an effect, so we can say that if the data supports an hypothesis or no, rather than just saying if there's a difference or no. So we used Bayesian factors here that I will show you the results the other slide, but here is just to say that when the factor is from 1 to 3, it's considered as like a weak evidence, and then 3 to 10 is moderate, and up to 10 and more, it was a strong evidence. So this is the framework we use. And for the self-reported measure and for the NFR amplitude, we compare each condition with the baseline to determine if the intervention worked. And then we compare the condition together to see if one intervention was better than the others. So here are the results. So we have the three variables that I mentioned here with all the contrast here. So I'll walk you to it a little bit. So first of all, as we may expected, the pain intensity tended to be lower in experimental condition compared to the baseline, even more for the VR alone. So we can see there's a very strong effect. For the unpleasantness, it was a bit more moderate or anecdotal. So, but the pain was lower in the tree condition compared to baseline. And then for the reflex amplitude, we can see that there is also strong effect. So the amplitude was lower during the VR and VRH compared to the baseline. So all three interventions reduce pain, unpleasantness, and NFR compared to the baseline. But as we can see, the contrast between the experimental conditions suggests that they all have comparable effects on the variables. So it seems like there's no really a method that is more effective than the other here. So they do not really differ. So this is very interesting. So this is our key findings. So all three interventions reduce pain compared to the baseline, but none outperform the others. VR and VRH shows stronger and more consistent evidence than hypnosis alone, particularly on the NFR, which is reflecting the spinal processing. And this can implicate that, well, as we said before, the VR appears as a promising approach for pain management, but the addition of hypnosis does not consistently improve the effects. And VRH may require further refinement because these techniques could operate through partly overlapping or even interfering mechanism.
So the limits of this study is that we had a small sample, 24 participants, and healthy subject from like students in psychology. So there is a limited clinical generalizability for patients. Maybe we can, in future studies, ask people from other field, not in psychology, but other field to answer the questions and participate. The experimental electrical pain is not the reflect of the pain that patients can have in intensive care units. So this is something that we have to keep in mind, that maybe we have a reduction of the pain here, and that doesn't mean that will work with patients in the real context. The hypnotic script focused on relaxation. Maybe in another study, it could focus on analgesic suggestion directly. And also at this time, VR was not a really high quality. I think that now the entreprise worked a lot on the quality of the image. So this is something that we have to take into consideration. The most important result, we think, was the fact that not even we didn't find that VRH is more effective, but we also find that maybe there is an interference between VR and hypnosis. As Karsten told in the previous study, this is a multisensory immersive engagement. So maybe it's overwhelmed the brain and the attentional resources, which is important to know when using that with patients because they already have low cognitive resources. Yes, so our results showed that hypnosis can be combined with a lot of techniques, not only VR, but also movement and meditation and a lot of techniques. So this is VR is just one possibility for hypnosis to be used. And what is also interesting that we did not find in the pain result, but we find that in the by talking with patients, is the fact that when they use hypnosis with VR once or twice, they don't really have a reduction of the pain, but they have another state of consciousness, like dissociation, and they are in an immersive environment. And what is interesting is that even after, when they just think about this environment, they are able to reproduce the same state of mind, the emotional state, and they can remember easily, okay, that was the lake, and I feel that, and I feel that. So this is a possibility to learn about self-hypnosis. Also, there is a need to do more ergonomic studies, not only efficacy studies, to know better for who, when, and how this tool can be used, and create a better integration of VR and hypnotic suggestion. What I suggest here is less is more. It's like to reduce the overwhelming effects, we can use a beautiful landscape, very high quality, and some suggestion sometimes to help people to go in the immersive experience, but not ask them to do an exercise, a mental exercise, just to be there and relax. We can also assess hypnotizability in the studies to understand if there is differences between the profile. And we told it, but technical quality of VR, not only in the image, but also in the facility to use it. Large samples and evaluate VRH in other clinical contexts. All of these studies the purpose is to consider a personalized approach to pain management and a very patient-centered approach. So all the results we find is not an answer about, yes, it works, or no, it doesn't work. This is not this. This is more than this. This is we have some clues here, we have some indication here. Can we put everything together to give to the patient we have in front of us the best possible way to manage pain. Thank you so much for inviting us. Thank you for your question and everything. Thank you.
Thank you. Thank you so much.
Thank you to the co-author also and the collaborators of the study.
Yes.
Thank you, guys. Very interesting stuff. And of course, begs the question exactly, it's a complex picture using virtual reality in this case, as many of the digital tech. Are we in a position to effectively prescribe this in a super effective way for everybody? No, I think that's the answer, and we probably expected that. But I think there's some real useful nuggets in there about how it could be applied in clinical practice, and what some of the effects are, and what we can expect from doing so. Thank you to both presentations. Very, very interesting stuff, guys. Thank you so much. We have about 10 minutes left, so please get your questions in. We'll try and fly through them as much as possible. Very, very interesting presentation. So as long as we've got those in, we can have some discussion now. So thank you so much. So we do have a question from an anonymous person. I did mention that you can submit the questions anonymously as well, so please feel free to do that. Mentioning, have you done any research regarding the VR efficacy in chronic pain management, and perhaps reflect on what your findings are and how that might influence the use of VR in chronic pain management? We'll come to you first, Carsten. What are your thoughts about VR in chronic pain?
Oh yeah, thank you for that question. My safe answer would be no. I only studied acute pain, but I wanna address that important question he has about chronic pain. How can we do that? Because we know that drugs is not cutting the case for these chronic patients. We're trying to lower that, and that's the mechanism we're lowering into to modulate the pain. Is also that's been the latest development of chronic pain management is how can we have the patients to cope with this situation they are in. And we're talking into the mechanism of virtual reality. Maybe virtual reality can enhance the top-down mechanism that we already have and that we know is going on in the brain. Can we speed up that process? So I definitely see that virtual reality can work along with that.
And it's how it translates into the management of chronic pain, which has so many differences from the management of acute pain. Very interesting. Florian, Emily, anything to add to that?
Yes, I think this is more efficient in acute pain because this is one spontaneous punctual effect, very quick with the immersive induction. But for chronic pain, maybe VR can help inside the therapy or inside what the person is already doing for his management of pain. This is not the VR that will help pain, but it will help the therapy. It will help to have more tools.
And it's interesting, like trying to pinpoint the exact use case for these individuals is quite difficult, of course. And Bart makes a very good point there that, considering the fact that there were hardly any side effects in the research that you reported, there would suggest that a larger sample needs to be done. I think side effects for the use of VR and other XR technologies in pain management are quite heavily reported. They're usually quite prominent in the research. And I think when you speak to clinicians, people who want to implement this in clinical practice, the side effects are usually the thing that come to the forefront about nausea. And you mentioned there, Florian and Emily, that you did a very brief kind of one session for people to be acclimatized to using the technology, which of course, if anybody has used it, can sit quite heavily on your head if it's a head-mounted device. Emily, was that was the intention around that kind of initial sessions to try and identify perhaps if individuals would react adversely to wearing a head-mounted display or using VR?
Yes, this was the goal because we knew that it would probably happen, and we wanted people to be able to tell us how they felt, if it was okay for them, or if they just didn't want to go through the second session. So this was mainly the goal. So yeah, it was also a way for us to just test how we could work with this person, if this is comfortable for them. And we did not have any problems, if I remember well. But also, some people had like some phobias about water. So this is very specific about our case. But this was also a way for us to see if the person feels just comfortable, not necessarily with the VR, but with the context of the environment. So this serves the purposes, but yeah, it was something we kind of maybe expected.
I think that transitions very, very briefly into the management of phobias. I think it's a very suited tool for doing those things. But Carsten, please go ahead.
Yeah, Emily, I thank you for that comment. I think that's also some of the things that we have to consider: the content. What are we showing the patients? What is working for that patient or that patients? I've done RCTs, also one of some been published. What are the feelings and what are the expectations of virtual reality? So it really comes down to what does the person need for having these outcomes or to reach these results on anxiety, pain, or whatever we are trying to achieve. Some people want to be distracted with a movie, or some people just want to say, no, I don't want to use my brain. I just want to have some mindful something I doesn't want to have to be paying attention to. So I think it's really, Emily, what you're saying is the content specific is also important for the clinical framing.
Yes, and I would add that again, for the specific program that we use, some people um really had difficulty to watch what they had to watch, listening to the audio. For some people, as Florian said, it kind of interfered together. It was like too much, and the environment was just not for them. So it's obviously something we have to keep in mind because it totally changes the experience of the person. So it's very important.
And in a clinical setting, I see that also with patients. Some people say, no, this is too much. I can't talk. This is just give me some drugs. I just don't want to be here. But other people, they want to engage. They want to talk about the dog, and of course in awake surgery. And that's totally different to each person. And that's also the virtual reality content have to manage that the need.
Hmm. Hmm. I think this kind of reflects a little bit on how I see virtual reality and other technologies that are similar. Is that I've spoken to some patients and they say that it's an entertainment device and it's coming from the commercial side of games and things. So trying to implement that into for use of a better word, serious clinical situation where things matter, I guess. With regards to expectations, Carsten, it can be conflicting, and that can have a serious effect on the efficacy of these types of tools. And of course, my brain's thinking about the technology and how we're reliant upon other commercial organizations to develop this tech so that we can utilize it effectively. You mentioned, Carsten, in the past about the VR was a massive machine used in the military and huge things, and now we're at such small bits of tech and we're trying to get there. So you can see some development there, which is great. So what might future research look like? And I go to Felipe's question here. Is there an intention to evolve the experiment with VR and VRH interventions into an RCT, perhaps with a larger sample? Do you have this in plan, Emily, Florian? And if so, what type of barriers are you crossing with the design of this type of research, which can be quite complex, right? Are you planning this in the future?
Yes, in Montreal, we are doing a study in oncology. So it's different than the first time because the first time I was going in intensive care units and asking patients if they want to use the VR. But here we ask patients if they are in the hospital for like 2 weeks and for the care, and we just give the VR and we ask them if they want to use it by themselves. So this is another kind of study, and yes, this is always randomized, and we want to know if people can be able to use in an autonomous way, because one of the points is that there is not always a psychologist with them, that they can use the tool and they can go in hypnosis and in VR by themselves. And what we find is that it is really useful for like anxiety before painful care or a moment, precise moment. So they use it before, but this is not, we don't find long-term effect, even if they use it a lot of times. So that's why for chronic pain, maybe we have to think about other way to use it. But here we found in oncology that this is really nice to be distracted from a painful care, for example.
Mm-hmm. And I think that's a great point, and perhaps trying to find a paper here that I read not too long ago, but it was, what does the control group? What's the usual care? What's the control for something like virtual reality? If the definitions are so varied, putting someone in a head-mounted display and having a video, could we call that control? We'd like to, of course. It makes it easy, but it's such a complex thing about RCTs and control versus intervention. And this is an issue that's been plaguing VR research for such a long time. So I'm sure that would be one of the difficulties for something like this. But Carsten, please.
Yeah. We are doing a RCT study right now with virtual reality and taking some of the limitations we found in the systematic review. So we developed 5 or 4 different videos and testing virtual reality versus standard of care for patients going under kidney stone removal with ESVL surgery or treatment. And I think we need that, and also strong content where the patients can choose what is the best for them. We need proper headsets that is developed for the newest on the market sort of thing, and a settings that is controlled. Of course, you can't have it double blinded because you can see the headsets on there. Some studies have tried to have all the headsets on each control group in the intervention group, and they just turned off the VR. But the way we do it is, I'm not part of the collecting data, so I don't see that data. But you can't have double-blinded studies with VR. But is that a limitation, or is it just circumstances that we have to deal with?
Absolutely. It's something to consider. Yeah. Florian, please.
Yes, I think that we want to use pharmacological methods for evaluating psychological methods.
Mm,
And this is not really adequate. I think we have to think about a way to use randomized studies, but which are more adequate for what we want to know. And here, the presence of the psychologist, the presence of the people in the room, the involvement of the patients in hypnosis or VR is really important for the result. This is not a pill that we can just measure the effects, and that's why double blind for me is not adequate, and that patients have to be very conscious about what they do because we involve them in their own care, and that's why maybe it's working.
Mm-hmm. Mm-hmm. It's great, and these discussions could go on for a while. I know we're slightly over time, but I just want to round things up in something super useful for the attendees today. Thank you so much for being here. To all of our attendees, apologies that we've gone over time a little bit. So I just want to bring it back to kind of the thoughts about the webinar about when and how. If you could try and provide some recommendations about when this should be used, and perhaps maybe a very, very brief insight into things to consider when doing that. What would you say, Carsten? Let's come to you first. I guess when and how is the question.
when and how? I think it is determined by what patient do we have in the seat or in the operator's room. I'm used to some drugs work better for this situation and some drugs. So it's the same case with virtual reality. I see it as a tool in the toolbox. I bring it out and it works or it doesn't work. I bring out some other medication, it works, it doesn't work for that, or it is beneficial. So it have to be tailored or framed to the clinical settings.
It's a very, very fair answer, of course. Florian, would you like to add anything to that?
Yes, I think inside the therapy, inside the treatment, like not as a isolate tool. It's not this tool that will help for everything. It's just an addition to the actual treatment. And if the medical team is informed and can use it easily, this is better for them to use it on daily life work, and that will be easy for patients to also accept this tool and want to try. So the medical team is really important in that, and they will know which patient will be more conscious, more motivated to use it because they know their patients and they know the tool.
Yeah, for sure. And just before we come back to you there, Carsten, just want to give the floor to Emily. What do you think? When and how?
Well, I agree with what Florian said. I think it's about to be flexible to be able to personalize the approach for the patient and to be to testing and not be scared to maybe go back to what we did before or just to test across the treatment, as Florian said, because it can really be a tool that people will learn from and could use the abilities in other areas of their condition. So this can be, I think the main word is to be flexible and to be able to personalize because it can have, as we saw, maybe other effects that we might not want to have if we just not standardize the care for everyone.
Fantastic. That's a great round off. And Carsten, did you want to just squeeze something in there?
Sorry, yeah, I just saw a question popping up that's saying, why haven't you done some qualitative research? And we have done that. I have published a quality research because I think it's also important as the other people are mentioning. So all these RCTs, are they answering the question? And what about, the psychology outcomes? Is important? And I think that's really important also to address that, not just a lower significant result from pain on a scale, but what does people think about using virtual reality? And that's really important also to take that in consideration. Maybe we can show significance in whatever scale, but if people don't like it to have it on or in a surgical room, it's just ending in the drawer, and should not be the case.
Of course, of course. And Emily, final word.
Yeah, sorry. I just want to say that we also did a qualitative study with the study that we presented today. So some other people in the team really asked the question to people about what they think. So it was a very useful insight of what worked and what did not work in the context of our study. So we did that also.
Yeah, and I think there is quite a plethora of qualitative work for the implementation of VR in clinical practice, and of course, in the context of acute and chronic pain management. So feel free to go and find those resources on your search bar. So as usual, as always happens, time flies during these webinars. So I think we're going to have to bring this to a close. Thank you to everybody involved in today's webinar, Emily, Florian and Carsten, for your time today and for sharing your interesting work. As I mentioned before, this webinar is recorded, so you can access it via the EFIC Academy platform, the YouTube channel, and all the social media. Don't forget to share this online as well, so others can benefit from these really interesting discussions that we've had today. If you want to continue the discussion, you can access our Discord channel, where we're beginning to establish a place for continued discussions around our webinar topics. So if you have a chance, feel free to check it out. Melinda has popped the link into the discussion there. So again, thank you all for engaging and for your questions. Apologies for running over slightly on time. I hope that you have a fantastic rest of your day, and I hope to see you all on the next webinar. Thank you very much, guys.
Thank you.
Thank you so
Thank
much.
you very much.